All right. Good morning, everyone. Welcome to our weekly orthopedic surgery grand rounds. First, thank you all for all of the efforts last week with our residency interviews. I think we had a great showing, great turnout, and a lot of excitement and enthusiasm from the applicants, from our residents, from our faculty. So I think it all went very well and very happy with it. For today, we have a very special visiting professor, and I'll have Dr. Feely introduce Dr. Brophy.
All right, so it's my pleasure to introduce Dr. Brophy. Dr. Brophy and I, apparently, even though Rob does not know this, we were supposed to be co-fellows at HSS. So there's always a two-year person at HSS and a one-year contingent. And unbeknownst to Dr. Brophy, apparently he was secretly supposed to be the two-year person. So when I showed up, we were the only class ever to never have a HSS person. So Rob went to Stanford, played soccer at Stanford, apparently was one level above Dr. Diab when he went there, graduated Stanford 1 year before I finished there, then went on to WashU, went to HSS, was kind of a legend there because if you go through HSS, you keep hearing all these wonderful things about Dr. Brophy. And then he was a sports fellow, but all the attendings talk about Dr. Brophy as if he was supposed to be the two-year sports fellow. So when Rob quit the fellowship, as they say, and as Rob says, went and got a job at WashU, we kept being told, well, if Rob was here, this would have gone well, or if only Rob was here to tell you this, or if Rob was here, you wouldn't be covering this, and you would be covering the New York public school basketball teams. So since Rob ditched us because we had a very rough year that year, Rob has had an incredible career in sports, despite the fact that HSS barely supports him now. He has gone on to do amazing research above and beyond everything he had done at HSS. He has done not only amazing clinical research, but he's done really, really amazing translational research. And he's been a role model for me because if you look at the types of research that he does, he is one of the few people that bridges the basic science research and what's really translatable at a clinically applicable level. And I know you all read some of his articles last night for Journal Club, and I think those articles are really important in bridging what we can understand at a genetic level and how we can understand and affect patient care. But above that, Rob is just a great person to hang out with at meetings. He is incredibly prolific. He's published over 350 articles. Thanks to his website, I know his H index is really high. It's 68. That's higher than mine. It's higher than Drew's. It's even higher than Dr. Zhang's, who's trying to publish all the hip arthroscopy papers to bump him up. He's won pretty much every award, but above that, everybody who goes to WashU tells us he's a great educator, and he's not only that, he's a great surgeon. He serves as chair of the musculoskeletal committee, chair now. Chair of the musculoskeletal committee, so he runs how all the data is collected and collated for the NFL. And he's going to talk to us today about articular injury and the biology of synovial joints. So Rob, thank you.
Thank you, Brian, and thank you for the invitation to come here. It really is an honor to be at this amazing medical center and department, among many friends and colleagues. So it's a real pleasure. I really appreciate it. Ben, Brian, the whole team, thank you all. Really enjoyed last night. Looking forward to speaking today and having some discussions with cases. It is amazing. 20 years later, I can still learn about the fact that apparently, unbeknownst to me, I was supposed to stick around in New York for another year. So no wonder nobody talked to me for 5 years after I left HSS, but now I know why. So no, that really was news to me today. So anyway, thank you for literally inviting me here today. And one of the things that is near and dear to me, and Brian, so many of you here do a great job of this as well, kind of trying to do some of this basic science and translational research and relating it to the clinical problems we face. And there's many challenges in terms of the work and how to relate it. And I'll kind of talk about kind of one of the big areas I've worked on in that kind of work and go through that, and interested to hear people's thoughts, feedback, questions, criticisms. So look forward to hopefully talking and hearing from you here over the next hour or so. So real quick, I think it's very important to talk about, none of this is done in isolation or in a silo. So first, I just want to say thank you to just some of the many mentors I've had over the years at WashU, at HSS. And I know this is a great department with many great mentors as well. So I think it's a very important part of development for everybody. So I do want to say thank you to many of the people I've gotten to work with and who've helped me along the way. And then even more importantly, I think research is really a team effort. So none of this is done without the collaboration of many people in the lab, partners in practice, et cetera. So this is really a team effort in terms of putting this all together. In terms of disclosures, I don't have any conflicts of interest. These are my disclosures. And we did have funding for a variety, different funding for different parts of this work that I'm going to present today. So I think I got started on this relatively early on in my career. We're all familiar with sports medicine, lots of biomechanics, looking at joints, forces, widgets, what's going on. But there have been a lot of great advances in the biological sciences going on, and maybe for better or worse, interest in so-called biological treatments for many sports-related injuries, but really very little information or data upon which to kind of evaluate what we're doing, how we're impacting the joint. And that was kind of my interest to say, could we have a little more data to kind of help assess that and perhaps guide what we're doing? We're all familiar with the variety of structures that can be injured in the knee. And I think I got interested because I really wasn't aware of a lot of information about how these injuries really impact the biology of the knee. And the goal was really to say, can we get some information to start to understand that, with the more longer term goal of saying, can we start to predict who might be at risk for developing arthritis? And can we develop some better ways to kind of impact that or delay or prevent that, if you will. So that was kind of what got me interested in kind of doing some of this work. Today, what I'll kind of do is, and this will be the outline, it's a little bit linear in terms of time, but not exactly, but we'll talk about kind of some work where we start out in the meniscus, expanded to articular cartilage, started to look at the ACL. More recently, we've been looking at synovial fluid from knee injuries. We have some early kind of predictive potential, which is what we wanted way back at the beginning. We're also starting to branch out into some other joints. So that's kind of how we'll go through this morning. And, we're all familiar with the meniscus in terms of a very common injury, what it does biomechanically in the joint. Thought is typically acute traumatic tears in younger individuals versus more degenerative tears in older individuals, although again, it's not a perfect correlation. We're all familiar with the fact that it's associated with degenerative changes in the knee and ultimately leading to arthritis down the road. So we all know meniscus is common and is not ideal for the health of the knee joint. But when we got started, there was really relatively little known about the metabolic activity of the injured meniscus. And the thought was that maybe that gets affected by similar processes as affect the articular cartilage in the joint. And could we see if this starts to give us some information about what may happen in the joint down the road after a meniscus tear? So this was our first paper. I was fortunate to get an REF Young Investigator grant to fund this. And we looked at gene expression in the injured meniscus, and we were trying to see just a descriptive association between gene expression in the meniscus with certain characteristics of the patient and the injury pattern. And so what we did, we had about 30 patients. They either had isolated meniscus tears in an otherwise normal joint, or they had an ACL tear and an isolated meniscus tear. And we looked at the tissue to see what was going on in terms of gene expression for a number of kind of degenerative and inflammatory markers. And the idea was that there might be some impact of patient age, sex, and injury pattern on what we saw in the injured meniscus. And so what we did find is that we found differences based on age. We looked at patients under 40 who had elevated expression in the isolated meniscus tear patients of a number of sort of inflammatory markers. Similar, but not exactly the same for younger patients who had a combined ACL tear and meniscus tear. And then when we compared the combined injury pattern of ACL and meniscus tear to isolated meniscus tear, we did see a number of sort of inflammatory markers elevated in the combined injury pattern. And we did see decreased expression of aggrecan, or a more anabolic marker, in the combined injury pattern. So really at this point, just descriptive new information. It did show potentially clinically relevant differences kind of associated with age and injury pattern. And kind of our kind of, guess was that the catabolic activity could be the biological basis to predict patients at risk for progression of osteoarthritis down the road. But obviously this was just a snapshot. That was kind of hypothesized in our discussion. So that was kind of our first paper to look at this. And this led to, this is just a handful of some of a bunch of other papers we did following up, really kind of diving into the meniscus tears and trying to better understand what's going on biologically. So we had one paper where we really focused in on age, looking at about 70 patients. These will just kind of skim through relatively. What was interesting here was we found a correlation with age and BMI, but it was really impacted mostly by age. Obviously, there's that great association between age and BMI. So once you kind of iron that out, BMI was only independently associated with apelin, which is a metabolic gene. Although what's interesting is that's going to come up again and again. There are some changes in the metabolic genes that go on, in the meniscus that may have some impact on joint health. We did another one where we focused really at a higher detail down in at BMI, and we wanted to look at what happened with transcriptome-wide analysis, and we compared BMIs under 25, 25 to 30, and over 30. And it was interesting. We found a wide number of genes that varied by BMI, although it was interesting that there was a greater difference between obese and overweight than between overweight and lean. So it looks as though as you go further up in terms of weight and BMI, it may drive more changes in the meniscus from a biologic standpoint. Again, we hypothesize that some of these changes may relate to a biologic cause for increased arthritis with elevated BMI, in addition to an obvious mechanical cause. So we did find some differences that could be relevant in terms of risk of developing arthritis. We also tried to look at how that might relate to any degree of chondrosis in the knee. So we had some knees where, again, none of these knees had arthritis, but we did have some knees with some degree of early chondrosis in the joint. And we did find some association. Age still seemed to be predominant rather than chondrosis. But there was a little bit of differential in terms of looking at in younger patients, they did seem to respond to injury in a way that was appropriate and maintaining the differentiated phenotype. When they were older, they kind of just crapped out, were kind of proliferative and losing their focus. Again, something that may relate to what's going on in terms of the overall joint health. So again, these are just early surveys of kind of what's going on and how these factors relate to the meniscus. We had another one where we looked at OA and cartilage to look for changes present. We had some knees with kind of early grade 1 changes on X-ray or grade 2 and chondrosis, and we wanted to see how that related. This was a group that had a little more degeneration in the knee at the time of meniscal surgery. Again, we found some associations in terms of X-ray and MRI. What was interesting about this is adiponectin, again, one of these metabolic genes, actually had an inverse relationship. So when there was chondrosis on MRI, it actually was suppressed. Once it had progressed to some early changes on X-ray, it actually was elevated. So we kind of guessed that might be kind of where you are in the stage of disease. It initially gets suppressed, and then as you get further down the degenerative kind of phenotype, you start to have elevated expression. And this is just consistent with showing that metabolism may have a biological role in OA in addition to an obvious kind of mechanical role. So there does seem to be something about kind of that, unfortunately, more common body habitus that may have a biological relationship to joint health, not just the added mechanical force across the joint. We also did one looking at duration of symptoms. When we circle back with the ACL, you'll see kind of how we relate to that. But we wanted to see if patients had a meniscus, were symptomatic from a meniscus for a longer duration prior to surgery, if there was any association. This was relatively limited. Not a lot of genes showed up on that. There were some new genes and pathways that might be interesting that may deserve some further study, but it was something that we just wanted to look at, and it didn't seem to be as promising as some of the other studies that we had done in terms of how these relate. So what I've kind of talked to up to here is kind of some of these surveys and initial kind of things that I think are very sort of informative, more on the basic science than the truly translational side or getting into the clinical side. I think one of the papers that we felt was starting to take a step to be more translational was when we looked and compared traumatic to degenerative tears. So this is something that may have some more relevance in terms of what we're doing. And so we looked at about 50 patients based on history and tear pattern, defining them as either degenerative or traumatic tears. And we did find interesting differences. So the degenerative tears had an elevated expression of collagen 1A1, and the traumatic tears had an elevated expression of a number of inflammatory markers. And this was the first study, at least I'm aware of anything looking at showing a biological difference kind of between traumatic and degenerative tears. And there was a higher inflammatory catabolic response in the traumatic tears. We kind of hypothesized that this may have some relevance to clinical decision making, such as deciding whether to repair or resect these, how it may relate to developing OA, and may be able to help in terms of guiding therapeutic intervention, either to optimize healing and repairs or how the joint health progresses. So this was starting to be something that may have some clinical relevance, as we do more follow-up studies. So, but I think it was kind of trying to figure out, where can we start to use this information to guide us in terms of clinical decision making. So up until then, this had been very descriptive in terms of what we've been doing. So we wanted to kind of build on that initial information. And this was more to try to look at potentially the biology of joint degeneration. So when I was fortunate to get an AUSSM Sanofi OA grant, and that was where we started to compare tissue from patients undergoing metasectomy, kind of early disease state, versus patients going under total knees at kind of end stage disease state. So this was to see if we could start to kind of find some differences that define the evolution of the disease, which again may give us some more guidance in terms of potential treatment intervention. So this was where we compared transcriptome expression in the meniscus from patients with and without osteoarthritis. And these studies are a little more elaborate. These are smaller cohorts, but we were able to find a number of very interesting differentially expressed transcripts. About 170, a little over half were elevated early disease versus an OA. And some of the interesting genes there we show were elevated in OA, or there on the top, that were potentially have some relationship to arthritis and degeneration of the joint. What was interesting is in that in meniscus tears in the early stage of disease, we saw elevated expression of VEGF-A and this molecule on the right there, periostin. And so this was the first time we saw this gene periostin show up. Honestly, I didn't even know what it was. I was even more clueless about this than the fact that I was supposed to be the research fellow at HSS. But I started to learn about what periostin was. Actually studied more in periodontal disease. So it has a role in kind of collagen formation. It's expressed in collagen-rich fibrous tissue. More had been studied more in periodontal ligaments, but it has an influence in terms of response to injury and repair. And what was interesting is we found elevated expression in the injured meniscus, but there had been a few studies previously that showed elevated expression. So end-stage articular cartilage had elevated periostin. But in our study, it was elevated periostin in early stage meniscus tear compared to OA. So it was opposite what some other labs had found. Keep periostin in mind, because we will talk about that more as we go forward. So the other thing that we did with this grant was not only compare early stage disease to end stage disease, but we also started to branch into looking at articular cartilage. So obviously it's easy to get articular cartilage from a total knee. What I did was basically consent patients going into surgery. I basically did like a Macy ACI biopsy off the notch of patients undergoing partial meniscectomy. Okay. We're going to use this just for science, but we'd like to look at this and try to help understand better what's going on in the knee. So fortunately, we had patients who were willing to do that. And we were able to now compare articular cartilage across these disease states. So again, we wanted to look at some of these findings and see how that related to our meniscal findings. What was interesting in this study is that we took these samples, we assessed them, and we actually, so these were knees with no arthritis, just a meniscus tear. We took a little sample off the notch, and we wanted to look at kind of how this related to known genes associated with osteoarthritis. So we called it kind of normal phenotype patients with a meniscus tear, supposedly an early stage disease. So a lot of the stuff we did in meniscus, we found similar relationships, again, more descriptional, not worth spending a lot of relative amount of time on. But what was really interesting is that we kind of could cluster these 12 patients into different groups based on how much they were expressing in terms of these kind of OA genes. And what was interesting is that we actually found a subset of 3 patients who their knee was phenotypically still normal with no arthritis on x-ray and no chondrosis in the rest of the knee. but their articular cartilage was already expressing 37 of 38 transcripts were upregulated that are associated with arthritis, and 5 out of 9 were downregulated in the same direction as arthritis. So these were patients who knee looked normal, they had a meniscus tear, but already their articular cartilage was going south if you looked at it from a biological standpoint. So again, very early and speculative, but is this maybe a way of kind of identifying people who may be at elevated risk for the joint kind of going south relatively quickly? And that was kind of interesting in terms of what we found with this data set. So no, I was not aware of any previous study looking at articular cartilage from patients undergoing partial meniscectomy. It was interesting to have this subset of patients who had kind of the genotype for early OA with a normal phenotype. You know, the speculation was that could this be a mechanism for stratifying OA risk in these patients? Obviously, a lot more study is needed, but it's interesting that you see this kind of stratification in patients even early on in terms of how the articular cartilage, the health of the articular cartilage, if you will. So that was an interesting study in terms of looking at that. We also, similar to meniscus, we compared the articular cartilage in the meniscus tear patients to the articular cartilage from knees undergoing knee replacement. Again, same technique. And we found, again, a number of interesting samples and differences that might be associated with kind of development of arthritis and response to injury in terms of comparing total knees to meniscectomy patients. This was one of the few studies where we looked at a couple of other types of RNAs as well that may deserve further study in terms of how they relate to joint health and risk of arthritis as well. So again, early kind of identification of information, differences at different stages of the disease. Obviously, not a lot more study is needed to say, you know, how do these relate to the development of OA mechanistically, and are they useful in terms of predicting who may develop arthritis, you know, down the road after knee injury. So at this time, we also started thinking about looking at the anterior cruciate ligament. And again, everyone's familiar with it from a clinical side, and also another injury associated with developing arthritis. One of the other things is that there's this movement or discussion or interest potentially, and is there the ability to kind of repair and heal an injured ACL versus do the reconstruction surgery that we typically do. But again, I think there's relative lack of information in terms of what the injured ACL is from a biological standpoint. And so we wanted to kind of start to look at that, see, could you take the injured ACL and learn from that in terms of what's going on in the biology of the torn ligament. So this was a paper where we looked at gene expression in the, in ACL tears and looked at how that might relate to time from injury. So patients undergoing ACL reconstruction after a chronic tear, how does that compare to patients who are getting reconstructed, you know, relatively acutely? And so we had 24 patients, and we kind of compared those who were undergoing reconstruction within 3 months of injury, and we called that acute, to intermediate, kind of 3 to 12 months from their ACL tear. And then we had patients who were more than 12 months out from their ACL tear. And we wanted to see how gene expression would change. And what was interesting, we found some differences in collagen genes, which we were not surprised by. But what was interesting to us is that periostin popped up again here. So remember, we had seen that in one of our early studies. And then it looked as though periostin really was a gene of interest that changed in injured ACL tears, and it really was suppressed over time. So the acute tears were expressing a fair amount of periostin, and the chronic ACL tears really had suppressed periostin expression. So that was very interesting to us in terms of thinking about, is periostin something that's relevant to kind of injury in the joint? Because now it's showing up in a couple of different tissues as something that may have relevance to how the knee responds to injury. So, you know, we found some other biological processes in terms of it made sense. What's emphasized in acute tears right after injury, in intermediate tears, as you're kind of shifting, you know, from that acute response to more of a chronic response. And then what's going on as you get into that kind of that chronic tear where you're 12 months out from an ACL. And that kind of made sense in terms of what we saw differences in terms of biological processes that were expressed. after there's an injury, and is it something that we should take a look at more? And again, this is just a quick review in terms of what it does. What's interesting is that periostin really is upregulated in response to injury or trauma in tissue, and it's appropriate, but then it needs to be suppressed. Whereas sustained upregulation of periostin may be associated with chronic diseases that have been studied in terms of asthma and some cancers. So periostin seems to play a role when there's trauma or insult, and then how that gets regulated over time may relate to whether chronic disease gets set up. But at this point, it's changed a little bit over the last 10 years, but there was still not a lot of information in terms of periostin and how it relates to joint degeneration in OA. So this was where we started to shift into synovial fluid based on this, was we wanted to look at, so if the ACL is making the injured ACL is making a lot of periostin right after injury, probably there's some relationship to how much periostin is present in the synovial fluid. And so that's how we started to branch into that and look at periostin levels in synovial fluid after ACL tears. And this is where we really broke it down even further. So we looked at 30 days within a month of injury and compared that to 2 to 3 months after injury. And then also compared, excuse me, to what we see in synovial fluid from patients with OA at end stage disease. And so what we found is that it starts to go up in the first month, but then it really peaks in months 2 to 3 in terms of the periostin expression. Both of these are expressing, there's much higher levels of periostin in the effusion after an ACL tear compared to an effusion that you see in OA. So there clearly is this kind of release, and then kind of very shortly after injury, it goes up for a few months. But again, remember from our first study, we know it goes down eventually by the time you're 12 months out. But there is kind of this time response of periostin after an ACL tear. And what was interesting is we did look at the cells. So at a cellular level, periostin is being expressed by the cells that are left in the torn ACL at a higher level than what you see coming out of articular cartilage. And it tracks with what you're seeing in the synovial fluid. So it does seem as though periostin is kind of a marker that relates to where you are in the stage of ACL tear and then the response of the joint afterward. So it seems as though the ACL actually makes periostin after it's been injured, at least for several months before burning out by around the 1 year mark. So it looks as though the torn ACL is actually a source of periostin in the joint fluid. So that kind of led us then to do more work of saying, all right, should we now really look at synovial fluid and start to get a better understanding of what's going on in the synovial fluid and how that may relate to the joint health overall. So this was a study that we looked at, just looking across the board at knee effusions to see what's changed, what the fluid does in relationship to the ACL tear. And we were able to get an OREF career development grant to kind of drive this project, looking at what was going on in the joint. So we had over 100 patients with synovial fluid after an acute ACL tear. And we wanted to look at how the proteomics of that fluid related to a number of patient and injury variables, and see what that may relate. And so what was interesting is we did find, excuse me, a number of kind of sex-based, potentially clinically relevant differences between males and females, also between isolated ACL tears and tears that had a combined ACL and meniscus tear. And these are just some of the genes that showed differences that may be clinically relevant. What was interesting is we actually did find some differences based on location-specific bone bruise as well. So there were some proteins that were elevated if they had a bone bruise in the lateral femoral condyle. If they had a bone bruise in the lateral tibial plateau, they had suppressed glutathione peroxidase 1. These all relate to kind of response to injury in OA. And so this, again, there's some differences in how the knee responds if it does or doesn't have a bone bruise in those locations. So again, this was more descriptive, just saying, do we find these patient injury specific factors associated with what's going on in the synovial fluid? And a number of these molecules do appear to potentially have some relationship to arthritis risk in the joint. And again, more descriptive than a first step, but it gives a little more information, kind of what's happening, after we have an ACL tear in the knee. So then we did a follow-up where we actually had some of these patients who we aspirated in the office and at the OR to see kind of how that fluid changes in that short time frame. And so we were able to kind of look at what happens in that short window initially after injury. And we did find a number of distinctions between the two groups, where we had a number of about 130 proteins that changed, 90 increased, 40 decreased. And again, there were a number of interesting kind of clinically relevant proteins that changed even in that short kind of few week window between the clinic and the OR. And again, we see periostin, which we've seen over and over again, as well as a number of other proteins increasing in those first few weeks after injury. And then we had a number of proteins that were decreasing. Now, what was interesting is the proteins that went up were kind of inflammatory, catabolic proteins. The ones that went down are more anabolic, joint protective proteins. So it kind of shows that it's a less than ideal change, in the milieu. And it was consistent with some of the other studies. Some of these proteins have been found to be elevated in OA, and the ones that decreased over time are more chondroprotective and beneficial for the knee. So it seems as though the effusion evolves in a way that's not optimal for joint health, even in those first few weeks kind of after injury. And so, these may be interesting biomarkers in terms of risk of OA or what's going on in the joint. What we do with this, not clear. Are these ones we should track over time? Are these ones that identify potential targets for intervention? But it does start to show some interesting things going on in the joint, and in the joint synovial fluid after ACL tear. So we've kind of started to set the stage for hopefully, more studies to follow up and assess that. We had another one recently, again, looking at ACL injury and a number of factors. And this was another group, again, adding some information in terms of differences that we found, comparing ACL to OA, and then combined and isolated ACL tears. And again, there seems to be this difference where, the more severe injury pattern and the further you go out from injury, the less ideal kind of the synovial fluid is in terms of what it does to the rest of the joint. So I think we've built a lot of information that probably needs a lot more work. But at least, I think we're setting the stage for more studies to be done, hopefully by us and others, to kind of look at how this drives the biological impact of these injuries and what we can do maybe to start to intervene. Now, what's interesting is we did have another study that we went off of this, which was based on the fact that we saw this elevated periostin in synovial fluid after an ACL tear. And we wanted to look at is there a connection? Does the remnant ACL tear actually have an influence or effect on the chondrocytes in the joint? And kind of the theory was we were thinking that maybe periostin is the main driver or mediator of that. So this is where we had cartilage, we had normal, we had OA, we had samples of ACL tears. And this is just the basic data. We showed that kind of all the relationships of expression that we saw in the tissues were consistent with what we had done previously. So it kind of backed up, what we had seen. What was interesting is that periostin does induce MMP13 and suppress collagen 1A1 in chondrocytes. So periostin does have a more inflammatory and less, a less than ideal impact on the articular cartilage. And if you knock that down, then these genes all get suppressed in terms of influencing if you change what happens with periostin. But what was interesting here is we actually wanted to take the tissue remnants from the ACL and see what they did to the articular cartilage. So not just the molecules, but we actually set up the ACL tissues with chondrocytes to see what would happen comparing acute ACL tear tissue to chronic ACL tear. And again, all the expressions were kind of similar with what we found previously. But what was interesting is that acute ACL tears really didn't have a huge influence on the articular cartilage, but when you had chronic ACL tear remnants, they actually induced periostin, MMP13, and ADAMS4 in the chondrocyte. So it was like it wasn't necessarily the periostin that was doing it. We weren't quite sure what it was, but the chronic ACL tear remnants were actually less than ideal for the articular cartilage. So this kind of raised more questions than gave us answers, which is sometimes how research goes. But it, consistently showing the periostin is highly expressed in OA cartilage. It seems to drive cartilage degeneration. This again left us confused. We know what happens with periostin with chronicity of ACL tears, but if you put the torn ACL with articular cartilage, the chronic ACL seems to be worse for the articular cartilage than the acute ACL tear. So I think, again, it's trying to peel back the layers of the onion, and sometimes it gets more complicated. But clearly, periostein has some role in how the joint repairs and either degenerates or regenerates after injury. And we need to do more studies to kind of figure out exactly the mechanisms by which that goes. So this has kind of been a lot of our descriptive, if you will, laying the groundwork, building things, just trying to get information and understand kind of the picture we're looking at. What we have just started to get into is kind of looking at predictive potential of what this information does. So this was a study that one of our residents was able to get an OREF grant for. And this was, can we actually see if there's any predictive value in all this information that we collect? So what we were able to do is get about 30 patients back who we had baseline information on at 6-year follow-up and start to see, well, does this matter? Yeah, we've done all this, but is it, you know, where it does it have any relationship to what happens to our patients? So we had about 30 patients, average age of about 50, BMI 28. We had pretty reasonable follow-up, and basically, you know, almost 9 out of 10 had some degree of OA progression, with 2/3 in the medial compartment, and more than half had what we call rapid, which is at least 2 grades of progression in the medial compartment in these 6 years since they'd had their partial meniscectomy. So what was interesting is that when we look back at the baseline expression of the meniscus, it was the opposite of what we thought. So the patients who progressed actually had less expression in the injured meniscus at the time of injury. The patients who didn't progress actually had higher expression. It's honestly not what we had kind of thought would be the case going in. And it was kind of consistent. If you had rapid progression, that held up even more so in terms of some of the molecules. So there is some information in terms of what the injured meniscus does, but contrary to what we thought, actually having a more robust biologic response was better. Those patients actually were the patients who didn't get arthritis, and the patients who got arthritis, it was almost like the meniscus threw up the white flag and didn't even respond. And so it's kind of opposite of what we thought. Not sure if that's a healing response or just shows where the knee is on the degenerative chain of, you know, with the knee, how the knee is able to respond. But there does seem to be some information, at least in terms of what we're collecting, that may be predictive for what's going to happen down the road in terms of what we see there. So, and we talked about this last night. We've started to actually start to look at some other joints as well. I collaborated with Alex Aleem, and we discussed this last night, so we'll kind of go over it, well, their journal club. So this is where we started to look at it in the shoulder. So this was where we collected patients undergoing shoulder stabilization surgery versus total shoulder arthroplasty. This is where we took a little sample of cartilage off the anteroinferior glenoid. Again, we consented patients ahead of time to say, hey, can we take a little sample if you're having shoulder stabilization surgery? Half the time we're shaving it out anyway, but at least we can get some information and see what's going on with genes, comparing OA to instability, and what we defined as acute instability, which was 1 or 2 dislocations versus 3 or more dislocations that we call chronic. And similar to what we found in the knee, we did find some interesting differences. And where with instability, they had elevated expression of some ECM genes and some OA risk alleles, whereas in OA, they had elevated inflammation and elevated expression of other OA risk genes. What was interesting is we did find differences between acute and what we call chronic instability. So even if once you start to have 3 dislocations or more, you're starting to see biological differences in the articular cartilage that may be relevant to the risk for OA. We've also done some collaboration with our partners in the hip. So that has been an interesting way of applying some of this to what's going on with FAI, which is kind of a similar disease model, if you will. I don't pretend to be a hip expert. I just try to help out and collaborate here, so we won't dive into that. But we are starting to apply this in a variety of settings. So I think, you know, we have certainly developed a lot of baseline information looking at gene expression with injured tissue from the knee, how it relates to a number of factors. We've identified a number of genes that may be of interest to continue to follow, especially we think periostein, although we've done a bunch of work too on some of the metabolic genes, which we didn't talk about. They may have some relevance as well. We're just starting to see do we have any predictive potential, and we will try to do some more follow-up studies to develop that further, and also starting to branch out into other joints. So I think, again, I think these are first steps on a long journey where we need to validate some of these findings at a sort of at a variety of levels. We need to look at other tissues as well as other joints. All of these are identifying targets that we need to look mechanistically, whether it makes sense to do more study. We obviously need larger and longer follow-up to look at OA. And we do want to do some work also maybe comparing joints to see how much similarities are. They're not going to be exactly the same, but what goes on in the knee versus the hip. So hopefully we will down the road help start getting closer to identifying predictors of OA in the knee and other joints. Maybe identify new targets or interventions biologically that we can actually make a difference in terms of developing OA, because ultimately that's the goal, is can we delay or holy grail prevent OA after the. So thank you very much, and happy to entertain questions, criticism.
All right. Thank you, Dr. Brophy, and congrats on all of that impressive work. It's really great to go through it all. I think we have some time for questions, discussion. Yeah, Dr. Bach, then.
Thank you so much for coming. I was curious, so the slide that talked about chronic ACL tears and you found molecules that then were correlated with greater OA later in life. I think sometimes we talk to older patients whose activities don't involve lateral movement and cutting, and you talk about the not needing to repair the ACL. And so I'm just curious if that finding would change your discussion with those types of patients. Like, do you think that there is a reason to fix the ACL solely so that you can prevent maybe the progression from molecules?
So yeah, that was kind of an interesting thing that we don't want to speculate too much on, but our thought is more that I don't know that would indicate you have to reconstruct, but maybe it makes sense to debride it if that's the case. So I mean, it's an excellent question. Honestly, we don't know the answer, but the question is it bad to just leave a torn ACL in there? But I don't think that necessarily means to jump to you have to stabilize a joint that isn't unstable.
Thanks again for your talk. This is really informative. Kind of along those lines, I was wondering how this has changed your practice. Like, do you think there's a role in tapping joints after an ACL injury, getting rid of the effusion? And then when you're doing an ACL reconstruction, are you consciously trying to get rid of every last little bit of ACL in there?
So both excellent questions. I think, so we're not sure. So no, I don't tap every knee. I still do it mostly if they got a tense painful effusion or I need to help get the motion optimized preoperatively. But it's raised the thought of, is that something we should think about? The question is just tapping it really have that much of a benefit, right? I mean, they always come back. Usually they're more comfortable and their range is better. But it does raise a question, is there something we should be putting in there, right? And I think we talked about last night, Christian Latterman at Kentucky, now up in Boston, had done some things with cortisone injections kind of in the team. I still have concerns about doing cortisone for a number of reasons, but is there something we could put in there to alter that? It's an excellent question. So no, I'm not doing that all the time. We've kind of thought about that for some ways of studying that. Maybe some follow-up with this cohort, we'll be able to kind of see some stuff out that makes sure there's something there. My guess is you're going to need to do more than just that. And then the other question was,
like, have you changed the way you're doing your ACL reconstruction?
Yeah, right. So no, excellent question. And the thought there, I mean, I know there's, at least in Europe, there's thoughts of leaving as much as possible and putting the graft through the remnant and doing all this kind of stuff. So honestly, based on this, no. I mean, I usually clear it out to minimize risk of arthrofibrosis. I don't mind leaving some fibers to maybe get a little bit of, ingrowth at the origin of the insertion. I haven't gotten to the point of that. I don't know that guess what I don't know is it a volume response or not? Like, I don't think it's probably a great idea to leave the whole injured ACL. But usually you clean enough out at the time you're doing ACL. I'm not taking, more out than I would otherwise. So that was a good question. Haven't really changed what I'm doing.
Dr. Brophy, thank you for that. I'm a pediatric orthopedic surgeon, but I find that I learn every time I come to Grand Rounds. And when you started your talk, you pointed out that we've always been very mechanical in sports. And then at the end, you made the apology that you're not a hip surgeon, but I'm sitting here thinking, as you collaborate, do you think it's crazy that in the pediatric world that we would start to look at what the kind of work you're doing? Because when I think of hip disease in the child, all the treatments are mechanical, and we're trying to come up with some kind of biological approach, maybe a little bit in leg cavity. But even the dislocated hip, every time I open a dislocated hip, there's a big effusion. And is that an opportunity lost that we should be collaborating with you and starting to look at? Because we assume that hips that don't do well after dislocation, we always say it's a vascular insult, but it may not be. It may be more than that. Is there an opportunity there?
No, it's an excellent point, and always looking to collaborate or expand. I mean, I think that's true. We've started just kind of with the FAI cohort, but no, absolutely. I think, and there too, you're having that insult of the hip, slipping in and out of place and what all that's going on. So absolutely something maybe to learn from.
Yeah, I think that's a great hip cohort with FAI, because there's definitely an effusion in some of those joints and a pronounced inflammatory effect that causes the cartilage degeneration and symptoms. Going back to the acute ACL injury and kind of modifying that acute inflammatory response. I know we talked about last night, putting steroids in acutely is a little bit risky. One of our interns, Kevin Chen here, he's been looking at using Toradol for intra-articular injections, and we've been doing some research on that recently here. You guys thought about using NSAIDs in the joint for that?
No, I certainly would have less, off the cuff, I'd have less concern about doing that than cortisone. I think the one problem is, I don't think we know what the right degree of inflammation is, right? That's so cortisone, risk of infection, whatnot. But I actually, do we need to modulate it? Do we need to increase it actually initially and then suppress it? Do we need to suppress it right out of the gate? So I would have less concern about Toradol from a risk standpoint, but I still think we don't know for sure what we need to do, if that makes sense. So yeah, that would be a great candidate, but I would probably want to do that in a way where we're tracking what happens in terms of the inflammation and stuff to see what happens down the road.
Thanks, Dr. Brophy. Really impressive research. I'm one of the primary care sports people, and we're doing some PRP proteomic work, and I've been reading all your stuff. So I'm interested in some of your thoughts about the research process. How sensitive are these tests in terms of getting your results where you've got your acute injury, but then these people are walking around, they're going to work? How does that affect the results that you get from proteomics?
Well, I think, yes, there's no doubt, PRP is a whole nother conversation that we can talk about length, right? With all the variables that impact that. So yes, I think that's true. I think that's kind of, to me, that's where this is translational, right? These aren't animals in a lab. These are people living in a lab. That's the information. So yes, I agree there's an impact. Now, to some extent, is that something where we could study weight bearing versus non-weight bearing, or CPM or something along those lines? Maybe. Yes, I think that probably does have some relevance. But I think for this, it's clinically people are going to do what they're going to do. Does that make sense? So no, I think it's a great point, and it's something you could try to study in some degree. But I think that's right the fun of translational models, where you're not controlling all the variables.
So thank you for coming out. I have a question that's not really science related.
Recovering from what you told me.
I know, right? Right. Still recovering from that year. Can you talk a little bit about how you built this collaboration? Because clearly, as an orthopedic resident, you don't get transcriptomic training. And during your attendinghood, they don't send you off to PhD school to learn how to do this. So can you talk to the residents and trainees a little bit about how you went about finding the time to build the collaborative network to do this, how you carve out time to do this? Because clearly you take care of the Los Angeles Rams, or at least oh, wait, they moved. But you do so many other things
really
that you
wanna hurt me
can't be
today.
the person doing this. So how do you find time to do this and do this so effectively?
No, thanks, Brian. I think that, and that's kind of one of the things I hope I was bringing up in terms of mentorship and colleagues and collaborators. It really is a team effort. And so I think, to your point, believe it or not, I do actually fairly robust clinical practice. That's what I like to do my day job. I'm an orthopedic surgeon, but I enjoy doing this in collaboration with people. And so with other people, to your point, I think it's a matter of identifying wherever you are, who potential collaborators are. That's from speaking with people. It's maybe looking and doing a little online research to see what people are doing, what kind of techniques they're using, and kind of the work that they're doing. And then I think it's you have to reach out, you have to make time to connect and see what people are doing, see what their interest is. And then I think the most important thing is building a team relationship that works. And I think the important thing there is you got to understand what the basic scientists and the other people you're working with need in terms of, do they need you to get funding? Do they need you to provide samples? How do you build a relationship that works for both, right? You're running around during the day and you still have to make time to, do we do a quick call? Do we do a quick connection? They don't always want to meet on weekends and nights. So you have to figure out, how do you make that collaboration work and do it in a way that who you're working with also gets the credit and the papers and what they need in terms of out of it. I think that's one of the biggest things, is you can't make that team about me, about we, and you have to be able to do that with your collaborators. But I think if you do that, to your point, it's a great degree of leverage. I don't pretend to understand half of what this is. I mean, I have a big, they're much smarter than I am, but if you can build something where everybody works together, you bring your understanding of the clinical problem, you bring your access to patients and tissue and what's there, and try to make, peanut butter and the chocolate better together instead of just making it really well. So I think that's important. And I think that's how you can be really productive, because you need that leverage. I'm not spending time in the lab. I'm not trying to learn about these techniques.
Hi, Dr. Brophy. Nick Colibas, one of the sports surgeons here. Bring you back to clinical side and sort of follow up on Dr. Woolley's question when it comes to meniscus repair. With all you know about the environment in the joint, do you have a preference for biological support, fibrin clot, PRP, bone marrow venting? What do you do?
Great question. And I do think that there is definitely a role for that. I mean, I know the data is not fully supportive of it, but I still think there's something to, the meniscus repairs, I think, feel generally better and more reliably when you have ACL reconstruction and crap ton of blood and then put on in the joint. So I've gotten really to bone marrow economically, typically the notch on the compartment. And that's kind of what I use. If obviously we have an ACL construction. But that, now again, do I have any evidence for that, or that, nothing to say for sure why that should be the case. I do think you should do something. I don't think PRP is wrong or fibrin clot is wrong. I just think bone marrow venting is fairly straightforward technically, and I think probably more than that.
Rory, thank you so much. My name is Stefano Bini. I'm an arthroplasty surgeon. I was very interested in the work being done about 15, maybe 20 years ago now, on the activation of the complement cascade as a mechanism towards arthritis. But I didn't see you mention MAC or any of those kinds of proteins. Is that sort of gone by the wayside, or is that not an area for sure?
We just haven't seen that to a huge degree. So again, we've kind of let what we've found kind of lead us. So I am not as familiar with kind of where that is in terms of the current research. And it may still be a completely relevant thing, but just falling outside of, we haven't found consistent, differences in our tissue or synovial fluid to make us.
Thank you.
Thank you so much for your talk. Really interesting. There's so much data to go through. One question I had is, did you compare in OA knees the profiles of the, say, there's a medial compartment arthritis and again, told me the medial compartment versus the lateral compartment arthritis in some of the assays because, is it the synovial fluid that's in all of the joint or is it a mechanical factors in combination?
No, great question. So when we did the articular cartilage, it was always from the medial notch. So it was always medial meniscus tears and knees with medial compartment. So I can't remember to what extent the other compartments were always involved because they were knees that had at least some breakdown elsewhere. But to your point, whenever we did this, that's like same with the shoulder. We try to do the same location always.
The other question I had was basically a lot of the, this is transition between saying 1.5-fold increases or decreases, which a lot of your data was, which perfectly fine for biomarker. But then when you start thinking, okay, what targets? How do you make the jump from a 1.5 increase to say, hey, I'm interested in that as a potential therapeutic intervention?
No, and again, that's what I've tried. This is descriptive, right? I mean, we're just gathering information and trying to put some sort of understanding to start to do exactly what you're talking about. That's hopefully I was trying to bring that up. Is now you really need to say, okay, if you think this is relevant, mechanistically, what's going on? To your point, are we seeing differences, or are we actually seeing something that's fundamentally changing how the joint is operating and what's going on? And is it something that we can kind of so. For sure, that's kind of what I'm talking about. We need to dive down in terms of some of the differences that we find in terms of what we think may be relevant. Harry Austin, again, kept showing up a lot with a lot of differences. That's kind of why we've been looking at that. A bunch of stuff we've done that I haven't. I mean, we started doing some isoform research. I mean, we're trying to start to do exactly what.
Hey, Rob, thank you for coming. It's very, very impressive work, and obviously we follow you over the years. And I think it showed the department, showed a lot of our learners too, that you can have a busy clinical practice and also very active in the research. So congratulations over here. Thank you for coming to UCSF. We're going to spend more time afterwards for case discussion, but really appreciate you coming to visit us. Yeah.
Thanks, everybody.
All right, we have a plaque to commemorate your visit.
No, thank you.
And then
appreciate it.
We'll take like a 5-minute break and then restart with case conference in here for anyone.